Good morning, everyone. Today we will be discussing about the posterior segment manifestations of blunt trauma. This is part two of the presentation. So, what we will be discussing is macular hole, choroidal rupture, subretinal hemorrhage, chorioretinitis scleroprateria, retinal tears, and retinal detachment. So, coming to traumatic macular hole is opposed to the traumatic central discontinuity of the retinal layers. So, traumatic macular hole accounts for 10% of all the macular holes. PVD is typically absent, more eccentric and less circular than idiopathic macular hole. Horizontal diameter is significantly longer than vertical. There is no consensus of management. Spontaneous closure occurs in young patients and smaller holes, which is less than one third of the disc diameter, and without a fluid cuff. Late surgery lessens the chance of good anatomical recovery and functional recovery. This is a case where we had a pre-op, and this is the post-op showing the closure of the macular hole. So now coming to the second manifestation, which is choroidal rupture. Choroidal rupture is defined as post-traumatic discontinuity of the choroid, which may or may not be associated with discontinuity of the overlying retina. Choroidal rupture of the inner choroid, overlying brush membrane, and RPE, which are relatively inelastic, whereas the fortified collagenous sclera and the flexible retina are less likely to rupture. Incidence is 5 to 10% in the blunt traumas. Coming to two types of the choroidal rupture, there is a direct choroidal rupture and there is an indirect choroidal rupture. Direct choroidal rupture is uncommon, parallel to the aura at the site of the impact and usually anterior to the equator, whereas indirect choroidal rupture is more common, compressive injury to the posterior pole, which is associated with crescent-shaped tears occurring concentric to the disc. Majority occur temporal to the disc, may involve fovea. Patients with angioid streaks are more susceptible, associated with intraretinal and subretinal hemorrhages. This is an OCT of a choroidal rupture passing through the fovea with an overlying retina which is discontinuous. And this is an OCT of a choroidal rupture passing through the fovea with an overlying retina which is continuous. This is a picture of a choroidal rupture which shows a fundus picture montage showing a choroidal rupture with retinal tear, subretinal hemorrhage, and there is a macular degeneration also present. Coming to the next manifestation, which is a subretinal hemorrhage, collection of blood between the RP and the neurosensory retina. Subretinal hemorrhage is classified according to the size as small, medium, and massive. Small is less than 4 disc diameter, medium is more than 4 disc diameter, but does not extend beyond the temporal vascular arcade. And the last one is massive, which overspreads the temporal vascular arcade. This is an OCT showing a massive subretinal hemorrhage. So, the main damage of the photoreceptors occurs due to iron-related toxicity, impairment of the diffusion of oxygen and nutrients, mechanical damage due to the clot contraction. Treatment options, there is pneumatic displacement, intravitreal tissue plasminogen and activator injection with pneumatic displacement, subretinal injection of the tissue plasminogen with pneumatic displacement. This is a case which we had operated showing a pre-pneumatic displacement, and this is showing a post-pneumatic displacement with almost all the subretinal hemorrhage which is gone. Now coming to chorioretinitis scleroprateria, rupture of the choroid, overlying brush membrane, RPE, neurosensory retina, secondary to high velocity projectile hitting adjacent to the globe but not penetrating it. So this is a case. It looks usually very dangerous, but the major thing is that the visual acuity and the visual prognosis depends on whether the macula is involved or not. So this is one of the cases which we had seen in Arvind. This is a 18-year-old male who had sustained an injury while playing a gilli danda. The patient's presenting visual acuity was 20 by 40. Two adjacent chorioretinal tears you can see anterior to the equator with a thin strip of retina between them and bare sclera underneath. The teared up retinochoroidal complex is seen lying next to the tear. The management of chorioretinitis scleroprateria management is controversial. The incidence of acute retinal detachment is low. The chorioretinal scarring is usually present. Usually in young patient, formed vitreous and intact posterior highlight tamponades the breaks. Late RD has been reported in 1/4 of the patients. Retinal breaks at the site distance to the original choroidal rupture is usually noted. Visual prognosis, as I told, is depends upon the location of scleroprateria and the status of macula and optic nerve. Coming to the final thing, traumatic retinal tears and retinal detachment, neurosensory retinal detachment post-trauma due to the traumatic retinal tears. Pathophysiology, sudden and rapid globe distortion, anteroposterior shortening and equatorial elongation. Globe is unable to adequately stretch inelastic eye walls. Volume of the eye remains constant. Vitreous resistant to the compression. Generates tractional forces within the globe. Sites of the tears, there is vitreous based avulsion, abnormal sites of vitreal adhesion like which causes holes and horseshoe tears, coop injury where there is a full thickness necrosis at the site of the scleral impact, sudden PVD induction which causes horseshoe tears. Most common location of the retinal tears is the infratemporal quadrant. Retinal tear detachment may develop even years after the original trauma, so frequent follow-up is necessary. This is a picture of showing a giant retinal tear with retinal detachment post closed globe injury. This is a case which is a post closed globe injury, which is showing a superior giant retinal tear, a vitreous hemorrhage, and also you can see superior commotio retina also noted. Management, laser coagulation and cryopexy, retinal detachment associated with retinal dialysis, scleral buckling is the mode of treatment. Retinal detachment associated with giant retinal tear, pars plana vitrectomy is the mode of management. And as Dr. Piyush told, it's always important to record the baseline visual acuity, to document the presence of RAPD, to examine the presence of other eye for also trauma, and normal anterior segment vision should not deter the clinician from performing dilated fundus examination. Thank you. My regards to Dr. Piyush, Dr. Nari sir, and my fellow Anuja. Thank you.